to my Code Blue station. So today at Code Blue, obviously I am not going to take you through a basic cardiac life support from start to finish, your CPR from start to finish. I'm not going to take you through an ACLS class either. But in preparing this station, I really did have to think about what really needs to be put out there to every RN in the organization. Because when you think about it, when we look at all of the RNs we have in the hospital and the areas they cover, we cover all different types of areas in the hospital. And there is not one place in this building that is exempt from a patient in Code Blue. And for any of you who have been here for any length of time, like me, a number of years, we've attended codes in many, many places in this hospital, okay? Both inpatient and outpatient areas, as well as outside on the grounds. So with that said, there are various levels, widespread differences in both experience, skill level, comfort level with dealing with a patient in cardiac arrest, where we have to call a Code Blue. So there are a couple of things that I want to go through, one being the first responder role and the other being the second responder role. Because I think in a circumstance where there is a lot of confusion when we find a patient in Code Blue and there's a lot of chaos going on, I really need to provide some kind of path of order in the middle of that chaos. And then then everything else kind of falls into place. So we have the ICU and ED groups, like yourself, who are actually part of the code team and deal with Code Blue all the time. So for you, it becomes a business as usual kind of thing. Whereas in other areas of the hospital, the behavioral areas, if something happens on the grounds or in a non-clinical area, that is certainly not something that's expected. And if you're in an area where you are not familiar with dealing with Code Blue and you find a patient unresponsive, pulseless, and you have to start, it's terrifying. So what happens to people when they are terrified?
They freeze up.
You freeze up. You have, well, it's called stress response, right? You have an adrenaline dump. Your thoughts become scattered. You don't think straight. You don't remember a lot of what you know. Your heart speeds up. Your palms get sweaty. It's a human physiologic response. It's human physiology. And with that said, there's nothing that we can do to change human physiology, right? Except maybe just recognize it, know it for what it is, and say, okay, I need to take a deep breath. We're all nurses, and now we need to act, okay? So now I'm telling you, you can't think straight, you don't know what to do, you forget everything you know, and now I'm telling you, well, now you need to know what to do next. So it's really finding that balance. It's important because we sometimes have that business as usual team where you don't have that response coming head to head with a stress response and a high level of tension. And if you're not,
they don't mesh.
They don't mesh, and sometimes they hit head on. And what really needs to happen is we need to come together and form a cohesive unit to take care of the patient. So I just think that the business as usual team just needs to know, recognize, and understand that you're probably walking in to human physiology, to a stress response, and you need to be able to deal with that and kind of help those nurses rein it in. And whereas on the other side, when the business as usual team comes in, and you might be thinking, don't they understand what's going on here? My patient has coded, and they're so calm about it. Well, it's not because they don't understand, it's because they do understand and understand also well, because it's a skill that they do all the time. Okay, so let's go through first responder and second responder role. First responder role, I think, is pretty straightforward, right? Who's the first responder? Whoever finds the patient. You go in, you find the patient. So just like we did learn in CPR, you're assessing the patient for responsiveness. Are you okay? Are you okay? We're not okay. They're not responding. We go straight for the pulse down, right? Now we're circulation, airway breathing. Instead of checking that airway first, we're checking for the pulse for a good 5 to 10 seconds. If there's no pulse, we're immediately starting chest compressions and calling for, yelling for help. Somebody call code blue. Okay? And they tell us at least 2 inches in depth and at least 100 a minute. So what does that tell us without going into CPR class? It means don't be afraid to push. Don't be afraid to push. Good, strong, uninterrupted compressions are what this patient needs. Okay.
I'm doing hard flat circles.
Pretty straightforward for a first responder role. The second responder role, so you hear me yell, somebody call code blue. What do you do?
Oh yeah, bringing the code card. I'm
Yeah.
sorry, I didn't know if you were trying to get
Yeah.
me to say that I actually called the code.
Well, you're working in the emergency department, so in the emergency department, you don't necessarily pick up the phone and officially call code blue like they do on the inpatient side. On an inpatient unit, somebody, if it's not you, has to make sure that 22 is dialed so that a code blue can be called,
Just 22.
or 22 is the emergency line of the hospital. Let them know that you need code blue and what area you're in. If that call does not take place, the code team is not going to come, and we want the code team to come. So dial 22. Then, yes, we get the crash cart. On top of the crash cart, we have the AED. Okay? This is where things out there on the unit gets a little muddled up, a little confusing. Why? Even in the ED, where you're very accustomed to responding to code blue, and I'm not referring to those that you know are coming in. This is, you find someone unresponsive, pulseless, start CPR, call for a code. You have someone with the cart coming in, but you're not the only person coming into that room. You have a third person, a fourth person, a fifth person. Everyone's coming in. Everyone has that stress response, and now no one's yet defined a role. So it's who's doing what, okay? And what does the patient really need at that moment?
Pads placed and the monitor
The
turned on.
pads, yes, perfect. The pads, okay? Most adult cardiac arrest patients will be in a shockable rhythm. Most, okay? The best chance of survival for most of our adult cardiac arrest patients is going to be early defibrillation. Okay, that's why we have AEDs out in the community everywhere, so that a layperson can get the pads onto the patient. Okay, because we know that most adult cardiac arrest patients will be in a shockable rhythm. That's a fact. So in the hospital, we can't lose sight of that here. Okay, and there's a lot of other things going on, and everything will fall into place. But yes, if you have your hands on this cart with the AED, you are the second responder, which means your role is to put these pads on and operate the AED. Now, in the emergency department, you don't have the AED. The door is off so that you are manually reading the rhythm. Okay, that's okay. You may have to respond somewhere, maybe out on the grounds, where security is bringing you an AED, or somewhere in an outpatient area, or an area that you do respond to as part of the Code Blue team, where an AED is being used, or maybe that's what you have access to. Okay, so, but second responder, hands on the cart, responsible to put the pads on and operate the AED. So, the pads, these are the training pads. They look a little bit different on your unit, but what is consistent is that they have pictures. Okay, and I tell everyone, yeah, look at the pictures. It's okay to look at the pictures, that's why they're there. Okay, sometimes when you have that stress response, you forget your left and your right. That's what happens to me. I forget my left and right.
Have to do it.
When I'm under stress, yeah, you're kind of like, is it his left or my left, or really is that left at all? No, it's not left at all. Okay, so we look at the pictures, and we put the pads on the patient.
The other thing that I found is, before I worked ED and ICU and whatnot, I would get really nervous when a code would happen, and like say I was the one who had to do this, because I hardly ever did it. How the heck did I hook them up? Like
Oh,
I
this
would.
here. Well, you're.
I'm not literally asking you. I'm
Okay.
saying at that point, not doing it very often. I used to get nervous that I was hooking it up incorrectly.
Okay. Well, the daily crash cart checks. Okay, now for the purpose of this drill, this is not hooked up. The daily crash cart checks, this is already hooked up to the LifePak 20.
Okay.
It's not hooked up today for the purpose of the drill because I
Okay.
have this hooked up to a simulator.
All right.
Okay? But pads on the patient. Remember now, continuous compressions this whole time. I'm doing a lot of talking, but uninterrupted compressions. We turn on the AED.
Push
And it
analyze.
tells us exactly what to do. So it says to push analyze.
Analyzing now.
We push analyze.
Scan clear.
And it's going to tell us, does the patient need to be shocked or
Shock
not?
Advised.
And it says, yes, the patient does. It will automatically charge to
Scan
the appropriate
clear.
joules.
Push to shock.
I'm clear, you're clear, we're all clear. We can shock the patient, all right? And we're all waiting for a response, right? And then it reminds us, no, you need to go back and immediately start CPR, okay? So in AED mode, what's important to know here is up to this point, what the patient initially needs is not ACLS. You need
BLS.
BCLS. You need your basic CPR. That's what this patient needs right now. Needs compressions, early defibrillation, okay? Not that airway's not important, okay? But while the second responder is I've got my hands on the cart, my job is to put the pads on. I'm going to put the pads on, I'm going to operate the AED. Well, now the third, fourth, fifth person maybe that's in the room, somebody's going to go get the amber bag, right? They're going to bag the patient if the code team's not there yet. Somebody's maybe going to put the board underneath the patient, start an IV, make sure suction is set up. Those things are all going to start to fall into place. But in the meantime, that first responder, straightforward, but the second responder role is being carried out.
Okay.
Okay? And now, 2 minutes. Like we have 2 minutes now. Think, okay, what's next? For you ACLS nurses, you know that, okay, well, when the code team gets here, they're going to be wanting to push epinephrine. Let me get an epinephrine out and get that ready. Okay? They're going to be here probably at this time if you're on a unit where you're waiting for the code team to arrive.
Yeah.
But we're not anticipating their arrival to do something. We're not waiting for them to come. First responder, second responder role.
They can't even see the rhythm?
No.
Oh, it's
And
totally
this is
an AED?
this is totally an AED.
All right.
And that's important to know because sometimes it's terrifying for a nurse who is not ACLS, for some reason where ACLS is this mystical thing, okay, where I'm not ACLS, how I can't shock the patient. Yes, you can, because in basic cardiac life support, we learn how to initiate CPR and put the AED on the patient because most patients need that early defibrillation. You are not doing the assessment. This is doing the assessment. This machine is doing the assessment. Until the code team gets there, this is the code leader. It's a code leader, they're assessing the patient, and it's keeping time with that 2 minutes of CPR. So at the end of 2 minutes of CPR, and we're still in the middle of this chaos, you're like, oh, you hear this little voice, hey, I'm keeping time. I'm the code leader, and I'm telling you, I need to assess again. So now we can assess
Analyzing now.
the patient
Scan
again,
clear.
Okay.
and this will say maybe the patient needs to be shocked,
Shock advised.
maybe the patient doesn't, and that's okay.
CPR.
It tells us to immediately resume CPR.
Okay.
Now the code team is going to come, and they're going to open the door. You're going to open this door. Again, in the emergency department, you don't have that door, okay, because you're expected to manually read the rhythm.
Okay, I thought you were saying that on the floor you couldn't even get a rhythm, and I was like, how do you run?
No, in AED mode, you will not see the rhythm.
No.
And that's okay, all right? But when the code team gets there, you would open the door, and now you have what you're now used to seeing.
So it's just
Okay.
opening the door.
It's
that's
just
all.
opening the door, all right? And now you're in a manual mode,
Okay.
okay? So now, the code team comes in, and their job is to come and take the lead. So when they come and take the lead, right, now, I'm gonna read the rhythm. Whether it's you or the ICU nurse, the physician, I'm gonna read the rhythm, and they may manually select the energy, charge, and defibrillate the patient. So when I say they take the lead, I just wanna stress that the expectation is when the code team arrives, that they identify with, you know, Bethany, are you the nurse taking care of this patient? Yes, great, I need you to stay with me, okay? It's probable that in some bigger organizations that the code team assumes the care of the patient, but not here. Right, we have one nurse that shows up, so you want the nurse caring for the patient. And that goes for whether it be code blue or rapid response stroke. The nurse caring for that patient needs to stay with the team to assist in that care. Okay? And you know what? Out there on the units, if you've never been or you've never had the opportunity to participate in a code blue, let the ICU nurse know, or the nursing supervisor, hey, I've never been in a code blue. That's good information for the code team to have. Because you know that you need
right
to,
up and get right in there.
where to direct and assist. There's a role for everybody, okay? Or if it's been a while, it may have been a year or two. You know, we don't have a lot of inpatient codes anymore.
Which
thanks
is good.
Thanks to rapid response. Yeah, it's rapid response is doing its job where we're recognizing changes in patients earlier, we're intervening early on, and we're not getting to that point where a patient reaches code blue. So, do you have any questions? Okay. Very good. Thank you.